I'm Dr. Randy Martin with the Marcus Heart Valve Center at Piedmont Heart in Atlanta, and I'm really pleased to be joined by a good friend and a colleague, Dr. Roberto Lang. Roberto is professor of medicine and cardiology and director of the non-invasive lab at the University of Chicago. Roberto's also been past president of the American Society of Echo and has taught us everything about the mitral valve, everything I've ever known. Roberto, thanks for joining me.
Thank you.
So are we at the stage now with echo, three-dimensional or otherwise imaging, where we can unequivocally tell the mitral surgeon everything they need to know?
I think that 3D echo is indispensable to the assessment of the mitral valve. And I think the surgeons, at least in our case, and I'm sure they love these images, they get it. They look at it and they understand. They look at the image and tell you, you can just shut up now. Let me look at the image, because they get it.
They tell me that all the time anyhow. But so, I mean, you know, you've been in multiple publications and everything with David Adams, all the really good mitral repair surgeons. So are we accurate now that where we can identify indentations, clefts, perforations, subvalvular apparatus? Do we have that knowledge now?
I think that the big advantage of 3D echo is that you can look at this image and you can now accurately localize it, but not only localize it, you can also see the extent of it. With 2D echo, you need to get many cut planes and then you need to integrate them in your mind. And that's difficult for us to do, and they're certainly difficult for the surgeons. So I think, as I told at the beginning, I think it's indispensable to enhance. Another thing is you can decide which repair is really complicated, and you should send it to an expert center. So I think it has a very valuable place.
I obviously agree with you wholeheartedly, but one of the things that I've been struck by is that while it certainly teaches us surgical anatomy and the surgeon understands echo anatomy, do you think is the 3D imaging truly anatomic-like? In other words, are there dropout problems, artifact problems, things where we might say, gee, I think there might be a cleft or an indentation and we're not sure?
Well, that's a good question. I think that if talking about transesophageal echo, if you do it consecutively, you'll get really good data in about 80% of the patients. Right. 20% of the patients, situations like the ones that you explained could happen. But then you have to integrate the 2D with a color Doppler and the 3D, and you can certainly maybe come. It's definitely not infallible. It won't work every single time, but 80% of the time you can, with a lot of certainty, make a diagnosis.
And as I said, really not blowing smoke, you've really done a marvelous job of educating us. Roberto, there's so much emphasis initially on mitral valve repair. It was resect, and now, as people say, respect, where they're saving things using neocords and things like that. Your lab and you have really helped us sort of think about the subvalvular apparatus. Are we at the position where we're beginning to really understand, you know, where we can really look at the underneath of the valve, look at the chordal length, look at is P1 short and atretic and those sort of things?
So what we learned through somebody in the lab who had already some experience, that if you do the transgastric approach from the transesophageal in the long axis, you can very nicely look at the chords. And we are in the process of trying to study whether we could potentially predict the length, right, so that you could prepare these chords and you could then shorten. We have done it in about 20 patients. We need to do it more frequently in order to 100% make sure. And we also need to make sure that different people can measure and get the same distance. It is a tedious thing.
But well, the point I'm making is that I think it's to look at the entire mitral apparatus so that we don't think, okay, I'm just in the left atrium looking down at the valve. I need to look at not only the valve, but I need to look at the support structures and everything that a surgeon would need to know.
So what you say is absolutely correct. Meaning the respect in which we need to know about the anatomy of the submitral apparatus is something that can be done, and much better than what I had initially imagined. And I think that we need to sort of teach that and see if other people can do it. But I think you can get like spectacular images of the submitral apparatus.
It's interesting, and because you've seen a lot of them, and I certainly have too. When you start looking at the incredible spectrum of mitral valve pathology, and you start seeing, I was referring to P1 being atretic, but I've seen a lot of cases where I didn't really appreciate it. It was probably me more than the instrumentation, that the say P1 was really shortened, that there was a calcium bar extending down, things that the surgeon really wanted to know. That information's there. We just have to start thinking about looking at it. Isn't that correct?
I think, at the beginning with 3D echo, we looked at the valve and we all were amazed at what we saw. So we sort of forgot about the surrounding structures. Now imaging the mitral valve is sort of standard. So now I think is the time to try and analyze what we call the mitral valve complex, to look at the tissue, the papillary muscles, the submitral apparatus, and looking at the valve and quantifying things.
So you really have led this. Where are we going? Where are we 3 years from now? With there will obviously be transcatheter therapy. There are currently will be transcatheter therapies coming to the mitral valve. Where are we going to be with imaging of the mitral apparatus?
So that's actually a very it's a great question. I think that what is going to happen, in my mind, things need to become automated. We can't spend 20 minutes twiggling with an image. We don't have the time. So things have to become automated. I think eventually using, computer intelligence will be able to make a diagnosis in an automated way. And I think also that we need to miniaturize things. In the meantime, when we do a procedure in the cath lab, we need to use general anesthesia, and it's a huge setup of a lot of people. If we had guidance that were smaller, maybe we could do this with conscious sedation, or maybe we could do it without. I think 3D echo got really lucky, because 3D echo was born completely without knowing about structural heart disease. And then these two things happened at the same time, and then everybody embraced it. So this was not thought about, this just happened.
Right.
And I think that this explosion of structural heart disease, which in your center is phenomenal, truly leads also the road in understanding how imaging and 3D echo can guide a procedure.
Well, I think you're right. I mean, I think that we're gonna enter the time when computer applications, miniaturization, simple quantification, reproducibility is going to be very important. But the mitral and the tricuspid are going to be really dramatic applications for our echo knowledge. Isn't that correct?
Yes, and that you bring something that is very important. The tricuspid valve, we never paid attention to it. Now it became apparent, and actually one sonographer in my lab sort of figured that out, that you can image it from the transthoracic point of view and get beautiful images, much better than with a transesophageal approach. So now I think this is spreading, and the amount of, in the meantime, the companies are not interested because they have not developed software. But I think that will happen, and the tricuspid valve will become a very important part.
Well, you see it. I mean, you see it in the surgeons now. Obviously, from Gilles Dreyfus's initial 4 centimeters, the magic number. But now, not only knowing when and where to measure the tricuspid annulus, but tricuspid anatomy, and certainly, I think that's going to be a strong point. Well, you've done. As I said, I really mean it. You've been a leader in teaching us about three-dimensional anatomy of the mitral valve and soon to be the tricuspid valve, and thank you very much.
Thank you, Randy.
Thank you for joining us. Thank you for joining us. We hope that you'll come back to view more.